Professor Emeritus, Department of Cellular Tantra, SDMC Udupi to take over the session. Welcome, sir.
Okay. In the last session, we had discussed about the migraine as the main disorder. Now, from the clinical point of view, there are certain migraine variants which can present with a slightly atypical clinical presentation, but still they are treated on the same lines of migraine. So we consider them as migraine variants. Of course, in neurology textbooks, you will have lots of other classification, lots of issues which make the issues more complicated. But I try to make it as simple as possible. And from the clinical point of view, the type of migraine which are migraine variants which are often seen and can produce some confusion with the diagnosis of migraine are mainly hemiplegic migraine, retinal migraine, chronic migraine, and episodic syndromes that may be associated with the migraine. Now, whenever there is a patient presenting with a headache, that typical presentations of the headache, if the patient has episodes of prolonged visual auras, if the patient has the visual auras persisting for hours together, or the patient has a atypical sensory or visual aura, where the loss of sensation in some areas of the body or loss of movement in some areas of the body prior to the headache, or if the patient presents with the confusion, dysarthria, or if the patient presents with the local focal neurological deficit like loss of movements anywhere, or if the patient presents with the severe gastrointestinal manifestations, or if the patient presents with other constitutional symptoms like giddiness or maybe diarrhea and so on, these conditions are suggestive of a possibility of a diagnosis other than that of the migraine, and you will have to go for further investigations and confirm whether there is any other systemic pathology or not, then confirm the migraine as such. Now, in case of the ophthalmic migraine, or hemiplegic retinal migraine, there could be usually patients present with childhood periodic vomiting, history of vomiting occurring repeatedly, that periodic vomiting, cyclical vomiting, right? And abdominal migraine, severe pain in the abdomen, also are commonly seen in children, and usually it occurs in the children below age of 10 years. This is one of the variant which should be ruled out whenever the patient has an atypical symptom. It can be similar symptoms can be produced due to many other abdominal pathologies, and hence the clinical diagnosis can become difficult. So only after all the other series of investigations rule out the other pathologies, you may make the diagnosis of a migraine. Then basilar or retinal migraines are more frequent in adolescents or young adults, where the patient may have more of visual symptoms and the visual aura can persist for hours together. A migraine aura without headache is mainly encountered in adults with long-standing history of migraine in early life. The patient may have a aura but may not have a headache. This also is one of the atypical presentation. Hemiplegic migraine is familial and sporadic forms have been reported in all age groups. Alternating hemiplegia of childhood is exclusively to children younger than 18 months. Very young children before 18 months are very commonly presented with alternating hemiplegia, which also may produce a confusion with many other conditions. Now, the other typical clinical issues which are somewhat significant from the clinical point of view are: one is the hemiplegic migraine, where the typical clinical presentation will be recurrent headaches associated with the temporary unilateral hemiparesis or hemiplegia. It could be temporary paralysis or hemiplegia, which often produces confusion with a transient ischemic attack. But along with that, there could be a numbness or tingling with or without speech disturbances. Now, there are two types of from our clinical point of view, it's quite important to differentiate a stroke from a hemiplegic migraine. A patient presenting with headache and a neurological symptom, often we will always have a confusion with some space occupying lesion. But if it is a temporary hemiparesis along with headache, it could be a hemiplegic migraine. But there again, you need to rule out other conditions like the meningitis like conditions, which also have to be ruled out. So investigations are absolutely necessary. Only when you have all the investigations are negative, then you may conclude that it is a migraine as such. Now, as far as hemiplegic migraine are concerned, there are two forms. One is familial migraine, hemiplegic migraine, and sporadic hemiplegic migraine. For hemiplegic migraine, genetic testing is available and by a PCR testing or PET scanning also shows this. So in a high level setup, these investigations can help in making out a familial hemiplegic migraine. Whereas a sporadic migraine is having with motor weakness and absence of a familial history of similar attacks. And one of the important things from the contemporary point of view are triptans and ergotamine preparations are contraindicated because of the vasoconstrictive effect in a familial hemiplegic migraine. Now, of course, when in Ayurvedic setup we may not prescribe this, but in those setup where they prescribe, this is contraindicated, and the treatment should be acute treatment should be antiemetics, non-steroidal anti-inflammatory drugs, and pain relievers would be the only other treatment in case of hemiplegic migraine as such. From Ayurvedic point of view, of course, we follow the same line as that of the other treatment, and it's not our classical treatment for migraine is not contraindicated in hemiplegic migraine conditions. Then the basilar migraine is another variety which also is comparatively common. I don't say very common, but commonly seen. Often we see them clinically, where the patient may have symptoms of complete giddiness and inability to maintain the position against gravity, dizziness, vertigo, or even ataxia, difficulty in walking, or tinnitus, and maybe nausea and vomiting along with the headache, or even there could be dysarthria, difficulty in speech also, diplopia also can occur, or bilateral paresthesias or altered sensations or altered consciousness also can occur, syncope, or sometimes a complete loss of consciousness, where the patient may have typically extrapyramidal symptoms, sudden onset along with the headache. That's the basilar migraine, also it's called as Bickerstaff syndrome. There again the treatment protocol is the same as the migraine. From our point of view also it is the same thing, there is no change in that. Then another of the condition which mimics migraine is cyclic vomiting syndrome. Recently we had a patient of cyclic vomiting syndrome, if you remember that. Cyclic vomiting often is in children but also can be seen in adults. The patient we had was in a later age group. The attacks are precipitated by either infection, menstruation, or emotional stress, and during the attacks the patient would have headache followed by severe vomiting, yawning, and lethargy. Children may show maybe something like attention deficit or somewhat showing some altered level of consciousness may be seen in children. Adults also may show a lot of confusion or maybe at times psychological symptoms. Often it may look like psychiatric issues in such conditions of cyclical vomiting syndromes. And again, there again, it's absolutely necessary to rule out the other conditions. So gastroscopy or other investigations may be necessary. And based upon the history, where the patient may have a bout of vomiting lasting for around 2 to 3 days along with the headache, and then subsides, and then again there could be recurrence of attacks with some precipitating factors, we may make the diagnosis of cyclical vomiting syndrome, and that the treatment is mainly intravenous fluids, particularly sufficient glucose is necessary, and analgesics may prevent the attack. And in the modern science, the tricyclic antidepressants and cyproheptadine are given. From our point of view, Smithsagar Rasa and Kamaduga are more dependable, and continuous use of Smithsagar Rasa and Kamaduga has prevented the episodes of cyclic vomiting for quite a long time in few of the patients whom we have treated. Then abdominal migraine is most typically in children, and it has been also been reported in adults occasionally. Typically, it complains of paroxysmal mid-abdominal pain. In the middle of the abdomen, there would be attacks of severe pain lasting from 1 to 72 hours, associated with nausea and vomiting, flushing, or pallor. As in cyclical vomiting, attacks may be associated with other migraine prodromes such as aura, or maybe headache, or maybe that fainting, fatigue, drowsiness, etc. Aura also may be absent in majority of the patient as such, or it may be very minimal. Usually, children show the deficit, attention deficit, or a subtle migraine as such. Abdominal migraine symptoms are usually relieved with the sleep. Once the patient sleeps, it becomes normal. Antiemetics may help in aborting the acute attack. For long-term prevention, contemporary medicine, flumarizine or calcium channel blockers are usually administered. From Ayurvedic point of view, again, what I would prescribe is Smisagarasa and Kamaduga, by which the attacks can be prevented significantly. Retinal migraine is one of the other issue which is comparatively rare, and it usually presents with the recurrent attacks of unilateral visual disturbance or blindness at times, lasting from minutes to 1 hour, which often may produce confusion with some seizure activity. Petit mal epilepsy like symptoms may be confused with that, with minimal or no headache also. When there is no headache, then that always produces confusion with the petit mal lesions, right? And patients describe the gradual visual disturbance in a mosaic pattern, something like scotomas, but blind spots in between which gradually enlarge, and then there could be a visual loss. Postural changes, exercise and oral contraceptives usually trigger the attacks as such. Now, important is ruling out eye disorders or vascular causes, especially when risk factors or arteriosclerosis exist. It is important. In old age, it's important to rule out that. So, a thorough investigation is absolutely necessary. Though the diagnosis of retinal migraine is clinical, that clinical diagnosis should be backed up by thorough investigation. That's absolutely important. And the prescription would be always, in the contemporary science, the typical standard migraine treatment like triptans and ergots should not be prescribed, and calcium channel blockers are preferred. From Ayurvedic point of view, again, it doesn't make much difference. We can manage the patients with the same Singsagarasa and Kamaduga as such. Then another variant of migraine which often can be seen is vertiginous migraine, or which also can be often diagnosed as vertigo. Vertigo diagnosis is based upon the involvement of the cochlear nerve, vestibulocochlear apparatus and vestibulocochlear nerve. In the absence of the vestibulocochlear involvement, if the patient presents with episodes of giddiness, nausea, vomiting and headache, along with that vertigo symptoms, then the provisional diagnosis of vestibular migraine may be, or vertiginous migraine may be made out. There again, the treatment protocol is the same. There is no change in the treatment protocol. So that's about the variants of migraine which have some clinical significance. The other huge varieties of the variants which are present in the text writing, they may not be very important from the clinical point of view. So we'll stop at that level about the migraine as such. The next condition which we discuss would be trigeminal neuralgia. Again, I have picked up the topics based upon the clinical significance from the point of view of the varieties of the patients whom you see, not from the conventional neurological methodology. So the picking up the topic is based upon the clinical significance, based upon the number of patients whom you see as such. So it's not, you may not see the same sequence in the neurological textbooks as such. Now anyway, trigeminal neuralgia or tic doulorex is one of the condition which is again commonly seen in Ayurvedic hospitals quite frequently. Now when I say that the incidents are more frequent patients whom we see in an Ayurvedic setup, and where the contemporary system often fails to produce the sufficient results, but you need to have all the thorough investigation procedures. So that's how I have selected the topics like. Now the trigeminal neuralgia is defined as a potentially disabling pain syndrome where the precise pathophysiology is not known. It remains obscure. The condition has to drive the patient to a brink of suicide because the pain is so severe, and that again makes the condition important. There will be acute and severe pain in the area. The exact etiology and pathophysiology remains controversial, but the important known factors, certain of the known factors are familial disposition. There is a tendency to have familial disposition as such, and often trigeminal neuralgia could be presented due to the tumors, identified tumors. And it's a classification of trigeminal neuralgia into primarily 3 categories: central, peripheral or both. And in 85% of the patients presenting with the trigeminal neuralgia, there will be no structural lesion. So many times they are categorized as a functional condition. Only vascular compression is believed to be the most common pathology. There will be a spasm as such, and based upon the statistics again, arterial compression is seen in 64% of such patients. Venous compression is seen in 36% of those patients where the structural lesions are identified. Remember again, in 85% it's not seen. A few of the patients, they will show all investigations show like there could be small micro zones of demyelination seen in the root of the trigeminal nerve. Then as far as the clinical presentation is concerned, females are more affected than the males. Range is about 3 to 2:1 in different statistics analysis. 90% of the patients, the disease begins after the age of 40 years with a typical onset of 60 to 70 years. So it's a generally disease of middle and later life. Patients who present with the disease when aged 20 to 40 years, younger age patients with trigeminal neuralgia are more likely to suffer from demyelinating lesion in the palms, so are secondary to multiple sclerosis. And hence, younger patients presented with the trigeminal neuralgia, you need to go for thorough investigations to rule out multiple sclerosis or any other demyelinating disorder. Multiple sclerosis and demyelinating disorders we will be discussing in due course of time, so there we go into that detail like how to confirm and how to rule out that. Younger patients also tend to have a secondary trigeminal neuralgia, so there is a high possibility of some other primary disease like a tumor pathology. So patients of trigeminal neuralgia presenting in a younger age group, you need to have very thorough investigation to rule out the primary condition, and that the treatment protocol would be totally different. Whereas neuralgia occurring at the later half of life, middle and later half of life, usually we have that typical what we call as a tics dolorex, where there may not be any organic pathology. The typical clinical presentation of a trigeminal neuralgia is severe pain, attacks of characteristically unilateral facial pain, again most often on the right side of the face. Reasons not known, why it is having a preference for the right side of the face not known. The number of attacks may vary from less than 1 per day to 12 or more per hour, or up to hundreds per day. So it can be various. The clinical presentation could be quite variable. There could be acute episodes of severe pain which last for a short duration, and then it may be like repeated episodes which can vary from 1 to hundreds per day also. Usually the triggers of the pain would be triggered when the patient chews, talks or smiles or drinks cold or hot substances. Touching, shaving or brushing of the teeth or blowing of the nose or exposing to the cold air or an open automobile window can trigger the pain. These are the commonly known triggering factors. So when a patient complains like after chewing or talking or any of these activities, there is a sudden acute current shock like pain. The usually patients prescribe that current shock like symptom lasting for a short duration, then you may suspect that it could be a trigeminal neuralgia. The pain is characteristically localized. Patient can exactly localize the area where the pain is felt, and they can map, like show in fingers and maybe show even diagram also. They can draw the diagram of the area where the pain is felt, and the pain commonly runs along the line dividing either the mandibular or maxillary nerves of the maxillary ophthalmic portions of the nerve. Trigeminal neuralgia anatomy, I think we didn't discuss about the anatomy. Mainly the trigeminal neuralgia anatomy is the trigeminal neuralgia would have an ophthalmic branch, then a mandibular branch and a maxillary branch, mainly 3, and from there you will have that different distribution to the areas of the face as such. And it could be like patient may have a typical area of the pain felt at the maxillary, mandibular or ophthalmic area as such. So the pain may be localized exactly in cases like in 60% of the patients the pain shoots from the corner of the mouth to the angle of the jaw. So it's a typical, in majority of the patients it starts from the corner of the mouth to the angle of the jaw. That line connecting these, that's the area where the pain starts in majority of the patients. In 30% the pain jolts from the upper lip to canine teeth to the eye and eyebrow, and maybe sparing the orbit. The patient may not have the pain in the eyeball but around the eyebrow. And these patients where the patient may be feeling the pain in the teeth would always have some confusion with the dental issue. So you need to again go for the dental examination and rule out the trigeminal neuralgia. And many of the dental issues also can present a similar like a triggered pain which is located at the canine teeth area and maybe reaching up to the face area. In less than 5% of the cases, pain involves ophthalmic branch and the facial nerve. So, ophthalmic branch and visual symptoms are comparatively rare. The characteristic qualities of the pain are they are very severe, paroxysmal, and lancinating. Lancinating is as if cutting through as a shula. Commences with a sensation of electric shocks in the affected area. The patient feels like there is electric shock. That's exactly the word used like. It reaches a peak within 20 seconds, less than 20 seconds, and very severe pain felt deep in the face, and it also affects the patient's expression. Patient's facial expression during the episode of pain would be very typically felt like the severe pain can be easily understood or easily can be appreciated by looking at the face of the patient. And it begins to fade within seconds. Within seconds, it gradually diminishes and giving for a burning ache for some seconds to minutes. The patient may have a burning sensation for seconds to minutes, and then it subsides. And there will be no pain between the attacks, absolutely, even though they are severe or frequent. Attacks may provoke patients to grimace, that beams, or make an aversive head movement. Because of the severity of the pain, you may see that abnormal movement of the body, and obvious movement like because of that it's called as a tic dolorex, where the patient may have that abnormal movement of the face and neck. It's called as tic dolorex. The other diagnostic clues from the clinical point of view is patients carefully avoid rubbing the face or shaving a trigger area, in contrast to other facial pain syndromes in which they massage the face or apply heat or ice. So other facial pain syndromes, we'll discuss about that other facial pain syndromes in due course of time. There the patient may be relieved by application of the hot or cold, so patients learn to do that. But whereas a trigeminal neuralgia patient avoids touching the area where the pain may be triggered. They may have that habit of avoiding shaving or touching or rubbing the area as such. And usually the patients may hold their head face still while talking or avoid precipitating an error. So the way they talk also looks very typical, where they minimize the movements of the lip in talking, and they do not move the head during the talking. Because of that repeated episodes of pain, they develop that habit. And unlike that of the migrainous pain, the trigeminal neuralgia doesn't occur during sleep. It's almost as a rule, it doesn't occur during sleep. Extremely rarely, a few of the patients may complain the pain during sleep and waking up from the sleep due to the pain. Now, these to rule out and to confirm about this typical pain, there is other facial pain conditions. There is a standard classification process, and that standard classification process is called as Eller's classification process, where it's a type 1 trigeminal neuralgia. Is the classic form of trigeminal neuralgia, where the patient would have episodes of pain. This is what we have already discussed. Now, the other variables, a trigeminal neuralgia type 2 is atypical form of trigeminal neuralgia, in which more constant pains, aching and throbbing can predominate, which can remain for a longer duration. That's called as type 2 as such, comparatively rare. But whenever you have that atypical presentation, a thorough investigation is necessary to rule out the other primary pathologies. And type 3 trigeminal neuropathic pain is another condition where patient may have a history of accidental or injury to the trigeminal nerve and brain pathways, and this is called as a trigeminal neuropathic pain, where the pain can become constant. The patient, that triggering phenomena may not be seen. Episodes of the pain may be related to the time interval of a day or a position of the head, or so on. So instead, unlike that of the triggering, it could be related to the other factors, variable factors. Then trigeminal deafferentiation pain is another of the condition where the patient may have the pain along the trigeminal nerve, and it's produced due to intentional injury or the system to attempt the trigeminal neuralgia, where the patient may have a numbness at a constant area of the part of the body. It's also called as anesthesial rest, where there will be a mechanical injury to the trigeminal nerve system. Then symptomatic trigeminal neuralgia is associated with the multiple sclerosis, where the patient may have multiple sclerosis, where the patient may have the trigeminal neuralgia like symptoms. Prosthetic neuralgia is a chronic facial pain that results from an outbreak of herpes zoster and usually in ophthalmic division. It's also called as a post-herpetic neuralgia also has to be ruled out. The geniculate neuralgia is a pain typified as episode of lancinating felt deeper in the ear, where there could be pathology in the ear. Glossopharyngeal neuralgia is where the patient may have pain in the tonsillar area or throat, usually triggered by talking or swallowing. Now these are also called as the facial pain syndromes. Of course, more details about a few of these conditions from the clinical point of view, like post-herpetic neuralgia and the multiple sclerosis, we will discuss in detail later on. The other conditions, of course, may not be of much significance from the clinical point of view. Now, to make the diagnosis of trigeminal neuralgia, the standard criteria, universal criteria, presented by International Classification of Headache Disorders as such in 2004 is it should be paroxysmal attacks of pain lasting from a fraction of a second to 2 minutes, affecting one or more divisions of the trigeminal neuralgia and fulfilling the criteria B and C. The criteria B is pain has at least one of the following characters: intense, sharp, superficial or stabbing, and to precipitate it from trigger areas or by trigger factors. Trigger areas are some zones of the face where they are touched or stimulated, producing the pain. Trigger factors are like the chewing, talking and so on. Then attacks are stereotyped in the same typical result. In every attack would be presented exactly the clinical same manner, and no clinical evident neurological deficit. There will be no obvious deficit there, not attributed to another disorder. So when these preconditions are met with, so criteria 1A and any of these 2 of the B and that 4 criteria, you make the diagnosis of trigeminal neuralgia. This is the conventional method of confirming the diagnosis. Important observation is no clinical evident neurological deficit. That means you need to rule out all the neurological deficits, or maybe by a thorough clinical examination, as well as you may have to go for the investigations to confirm the diagnosis of trigeminal neuralgia. To again highlight the same issues, primary differences, try to make out that from the clinical point of view. Again, summary, whatever we have discussed, the differences between the different types of conditions which can produce a confusion from the clinical point of view: trigeminal neuralgia, migraine, cluster headache, atypical facial pain conditions. Usually, the incidence ratio of trigeminal neuralgia is 1:2, male and female. Females are more common. Age of onset usually after 50 or 60 to 70. Localization is essentially unilateral. There will be no other symptoms, only the pain. Attack duration lasts for seconds. Cycles, it can continue for months together. And the provocation could be touch, washing, shaving and so on, whatever we have called as. For the migraine, there is no much difference between the male and female incidence, and it's about 1:1. Age is usually younger age. Localization, patient may not be able to, or it could be both the sides, area of left or right, or occasionally at times at some episodes left side, some episodes right side, or at times it could be any of the other facial area which we have discussed already in the migraine. The other clinical symptoms like photophobia, phonophobia or gastrointestinal symptoms like vomiting are quite common with the migraine. Attacks duration can be 4 to 72 hours, that migraine lasts for that, and the cycles could be days to weeks. Provocation, it's not possible to make out, often stress or other factors. Cluster headache, the ratio is 1:9. In females is more common. Age of onset is middle age, again 30 to 40. Always unilateral. Other clinical symptoms will be the conjunctival injection and discharges from the eyes tears before eyes, excess of discharge, or Horner syndrome where the pupillary constrictions could be atypical. Attacks last for 15 to 20 minutes. Cycles, it could be like, as we have discussed earlier, there will be episodes of headache continuously for a short duration, then there is a gap, then again continuous episodes of headache, and usually stress, and very often it occurs at night. Other atypical facial pain like conditions, it can occur in any of the condition, any of the age. Usually neck, ears and face are involved. Sensory abnormalities or motor abnormalities can occur. It can be lasting for hours to days. Stress and cold can trigger that. Of course, the same as such. Then CT and MRI are necessary to rule out intracranial tumors or multiple sclerosis. In all the cases of trigeminal neuralgia, the CT or MRI is necessary to rule out the other conditions like multiple sclerosis or intracranial tumors. And the other important clinical tests which are often used in sophisticated neurology centers, which may not be used in our setup, is what we call as a blink reflex. Blink reflex is giving a electrical stimulus over the face area and seeing the reflex of the closure of the eyelids. The trigeminal neuralgia, particularly idiopathic trigeminal neuralgia, there will be a 59 to 100% specificity of pattern of that blink. There will be rapid blinking of the eyebrows when a low voltage current is passed through over the skin area. There is a specific blink reflex assessing instrument, and with that it can be done. Just a low voltage current is seen, and you get the graph of the eyebrows, which is now considered as a standard test. Of course, in routine, in all clinical setup, you may not have that kind of an instrument, but in an advanced neurological center, you may have that, and that's now considered as the most reliable method of confirming a trigeminal neuralgia, idiopathic trigeminal neuralgia. Treatment as such is among the contemporary system of medicine, carbamazepine is considered to be the drug of choice. It relieves symptoms in 70%, but recurrence are common. One of the major problems is that would be the patient may have a very high response in the initial stages, but later on, gradually, the patients would have a diminished yield, or there is a diminishing returns in due course of time. Initially, it reduces the headache immediately at a low dose. 100 mg may produce a significant and complete relief within 2 hours, and then gradually the patient becomes somewhat resistant to that, or the same dose fails to produce a response. So the dose has to be increased, and it can be high as 600 to 1200 milligram. So and most of the patients who come to Ayurvedic treatment, they come with this kind of history, like the patient may have taken carbamazepine initially, and gradually the dose requirement has become increased, and many times that high dose may not be tolerated. Patient may have the adverse effects of that carbamazepine, and they may come to our Ayurvedic treatment. So majority of the patients who come to our Ayurvedic setup would be like those patients who have become resistant to this carbamazepine therapy. Then another drug which is now becoming quite popular and very commonly prescribed is gabapentin. Gabapentin is a empirical is a depressing drug. It reduces the neurological activity at the specified area, and gabapentin now is quite frequently prescribed in patients with any other acute pain symptoms, particularly these disc lesions and sciatica conditions. Also, gabapentin is quite frequently prescribed now, and it's also a treatment used in the trigeminal neuralgia. Gabapentin now has become a very popular drug for any symptomatic neuralgia conditions. Then the other line of treatment which is often tried is lamotrigine or baclofen. Many of the patients may come to us with this protocol treatment also. It's a quite costly protocol, and often the adverse effects also are quite huge, and I have seen many patients who do not really respond to this treatment even. Then the other drugs which are often occasionally used is phenytoin, and baclofen of course is a new introduction. It's a very recently introduced as such. Then the other options which are present in the contemporary system is a surgical treatment. 25 to 50% of the patients, when they stop responding to medical therapy, the surgical option is suggested. And the surgical options are either it's a local ablation of peripheral nerve and sectioning of the sensory nerves, damaging the nerves completely. Trigeminal nerve is damaged, but this technique now has become obsolete. Earlier, some 10 to 15 years earlier, this was very popular, but now it's obsolete because of the collateral damage and the later consequences, the lifestyle factors which are affected. So injection of nerve, this destroying drug like alcohol or phenol to the trigeminus, nucleus trigeminus is another of the treatment. The other popular treatment, gaining popular now, is either gamma knife radiosurgery, very costly and highly technical method of doing that, again nerve damage, or microvascular decompression are the other options of the treatment. From Ayurvedic point of view, the clinical presentation of Ardita mentioned by Sushruta. Now, Ardita mentioned in Sushruta and other Samhitas, they are slightly different. Ardita mentioned in Charaka and Vagbhata has a different presentation, whereas the symptoms of Ardita mentioned in Sushruta is exactly the clinical symptoms of trigeminal neuralgia, facial pain syndromes. The typical triggering factors are Uchirvyaharata, खादतः कठिनानि च हसतो जृम्बतो वापि भारात् विषमशायिनः शिरा नासौश्च चिबुकललाट ईक्षणचण्डिकः. That's exactly the same, ditto copying. The language is different. The triggering factors which we have discussed for the neuralgia are the same as mentioned in Srishula. And the clinical presentation will be Ardayati Adilaha Vapram Ardita Janayati Ukri Bhoti Vaktradam Griva Apavartate Shiraschalati Baksangaha Netra Dinam Chabaikradam Griva Chupukadantanam Tasmin Parshvecha Vedana. That acute pain producing that deformity, that tick presentation is the typical issue. Now, Yasya Agraja Romaharsha Veputu Netramavilam Vairurdhum Tvajit Swapaha Todo Manya Hanugraha Tamarditam Prahu Vyadhim Vyadhivichakshanaha, where there could be even discharges from the eyes, and there could be even that swapaha, impaired these levels of behavior changes, like that is sign of Ardita. The typical treatment for Ardita, as mentioned in the text, is Ardite Namanam Murti Tailam Shotrakshi Tarpanam Sashope Vamanam Dahara Vikte Sirabhyataha. But that's the typical protocol of the treatment mentioned in the text. But most of the patients we can manage better, much better than the contemporary system. So I would consider trigeminal neuralgia as an Ayurvedic disease because it can be managed better with Ayurvedic treatment than the other way. And my preferred prescription is Smritisakarasa, Ekankavira, Ashwagandharishta, Anutailanasya. In very severe cases where these treatment may not produce sufficient satisfactory response, Dashamula Niruhvaste and Tailadhara also are useful, and they help in resolution of the symptoms much better than the contemporary system. I don't say that that can be an absolute cure, but the resolution of the symptom will be much better, and there is no question of increasing the doses in due course of time with this protocol of the treatment. So that's about the trigeminal neuralgia. The next is we'll take up the facial nerve pathology or facial palsy. I think we'll take up this in the next session, 7:10. The time is slightly bit early, but I will take up that in the next session. If there are any questions, we'll try to answer and then wind up today. Right, there are no questions, so we'll wind up today. Thank you.